Hello and welcome to another episode of the Daily Remedy Podcast. Today we're here with longtime friend of the show, Dr. Neil Anand, who will discuss, among other things, his many FOIA requests and also what he's learning in terms of how federal agents, particularly the DEA and the DOJ, target physicians both for investigative and prosecutorial purposes. And with that, I'd like to welcome Dr. Anand.
Hi, Jay. Thanks for having me back on the show. I really appreciate it. I love your show. I think it's great. It's one of the best shows on in healthcare. So thank you so much for having me back.
Thank you. Appreciate it. So let's start with a few things that we've discussed before and then maybe build upon it. And I know that you've been at the vanguard in really identifying how federal government and state governments use patient prescribing information, physician prescribing information to then create the illusion of criminality or of misconduct. Tell us a little bit about that for those who have may not heard of your work before, and talk a little bit about some of the new things that you're finding through your FOIA requests.
Okay, so so basically, if we look at things historically, I want to start there. But historically, many physicians for many years weren't arrested in large numbers, and around 2000. Increasing numbers of physicians were being arrested, either for Controlled Substance Act violations or healthcare fraud or, False Claims Act or whatnot. And and it's been increasingly exponential in terms of the numbers of physicians that have been targeted, the numbers of physicians that have been charged, and the number of physicians that are being incarcerated. So much so that it's an epidemic among physicians. And so we wanted to look into that. There was me and a number of people, but we want to look at why is this happening? What's the cause? What's the root cause of what's happening in our society? And why are so many physicians, why do physicians have to become criminals in the first place? What is going on where all these physicians are now becoming criminals? What's happening? And and a lot of it has to do with the way the government is identifying physicians, their criminal forensic techniques, the tools that they're using, and how this process started, and where these ideas came from. So I've been concentrating more on that with the FOIA requests, and I've gotten 1,000 pages of information here and there, a couple hundred pages of information here and there. And then from that, I've been able to read through those and understand what their methodologies are and what they're using to target physicians.
So let's start with the FOIAs themselves. How are you drafting them, and who are you sending these FOIA requests to in order to obtain this information? Because you know more than anybody else that the federal government is very reluctant to hand over information that would possibly lead to their prejudicial behavior. So talk to us about the process of obtaining these documents in the first place.
Okay, so for Freedom Information Act, now I've targeted mostly executive branch agencies. You cannot file a Freedom Information Act in a judicial capacity. You cannot do it in congressional. You can only do it for executive branch agencies, either in the state level or the federal level. And what Freedom Information Act is that there's, the executive branch is supposed to enforce the law, but you want to have the law enforced evenly and fairly, and so that people value the law and see the purpose of the law. And so the purpose of the law is, to have an orderly society and maintain an orderly society. So when I filed the FOIAs, I filed it against the Drug Enforcement Agency in Washington, D.C. I filed it against Health and Human Services, and I filed it against Department of Justice, Office of Information Policy. The Office of Information Policy decides, a lot of how the executive branch is going to behave and what their policies are going to be. And I also filed it against the Solicitor General, because the Solicitor General made many statements during the oral arguments of the Ruan case, which was the first, physician case since Moore, arguing from the Supreme Court, and I wanted to see what they really had to say in terms of how they identify criminal behavior and whatnot. And so I have multiple FOIAs there, and I wasn't getting very many documents, so then I litigated because then you don't really get much information from the executive branch agencies until you litigate. And even when you litigate, um, you know, documents have been hard to come by because they're frankly to me very concerning, and that's why I'm trying to get it out there and trying to get some help in terms of uh, knowledge to physicians, knowledge to policymakers, so that they can look into this more so than just myself and the other small groups of physicians that are looking into this currently.
Perfect. So you've gone through this process. They refused, so then you litigate, and that's a big term, and I think it makes sense to go over it simply because your efforts have been, quite heroic in this sense. Tell us how you individually and a pro se manner have litigated the federal government to obtain these documents.
I just basically you file a lawsuit against the agency. You go, you pay your fee. Um, the court sends a summons. The summons, they brings the agency. The agency will have an attorney, and then you start litigating using the law of Freedom Information Act. And for me, because I have an ongoing criminal case, I have higher priority because you're supposed to be innocent until proven guilty, and you have a higher ability to obtain those documents. So I'm using uh, my criminal case as because I need these documents for my liberty. I have a liberty interest, and then in terms of um, I had a contract with these agents, so they had a duty of good faith and fair dealing when dealing with these federal agencies. So I want to see exactly how they determine who's a good doctor and who's a bad doctor, what methodologies they're using. And what we found predominantly is that they use data, and they use a process called data analytics. And what they do is they look at CPT codes and ICD 10 codes or ICD 9 codes back then and from so they can look at a doctor's diagnosis for each patient, and then through the CPT code they can look for each treatment, or if it's a HCPCS code, or they can look at what medications was given to the patient. They can also look at Part A, Part B, Part C, Part D for Medicare because they have these huge databases, and they can look at what medications the patients have. So oftentimes what they do is they look for outliers. And if you're an outlier, you're the patient receiving more money in terms of medication that you prescribe to a patient, or they receive more procedures, or they receive a certain code that other physicians aren't using or hospitals are using or whatever. They deem that as an outlier. And then they start concentrating on investigating why that outlier exists, and they assume that that outlier is because there's fraud or drug distribution or whatnot. And through this methodology, then they can target and take out, the what they have determined as a criminal identified healthcare provider or criminal identified physician. And they can keep doing this on over and over and over and again for years and years and years, and keep, arresting physicians. And another reason they do it, according to their documents, is then they can also take the assets of the physician or healthcare facility or whatever, and take all the assets of the physician through extrapolation. So they use some methodology called extrapolation. Well, they'll look at a certain number of records, 5 or 10 records, then give it to one of their experts, and the expert says, "Well, there's fraud in all of these 5 records, so we'll extrapolate it out, or these 10 records, and then there's multi-million dollars of fraud based on this extrapolation, and so then let's get everything that the doctor has ever earned in his entire life. This whole thing is fraud, and they've been doing it over and over again for thousands of doctors, not just hundreds of doctors, it's thousands of doctors. So I've also asked for lists from these agencies on, okay, because they put press statements out. They tout their successes in the press and whatnot. So I've asked, since 1990, when it really got juiced up, since 1990 onwards, tell us who the physicians are, tell us what they've been charged with, and your successes and your conviction. And they don't want to give any of that, which is to me surprising that they're willing to do it in the press, but they're not willing to give you the hard data. And so there's no real effort to identify the cause of all this by the agencies or rectifying the issue. They just want the issue to keep continuing.
Has in your documents, uh, and covered through FOIA and otherwise, uh, has there been any mentioning of the federal government or any one of its executive branches acknowledging that the data does not support their policy, or questioning why they're targeting physicians despite the rising overdoses?
Well, okay. So I have a few key documents, but in there in 2012, around 2012, in 2007, they started something. When Obamacare started, right? When Obamacare was started, they also started something called Healthcare Fraud Preventive Partnership. And that Healthcare Fraud Preventive Partnership had all the insurance companies, uh, in private insurance companies, public insurance companies, and the public insurance companies are Medicare, Medicaid. So they had the state agencies. So they had so they had a conglomerate basically, combined with Health and Human Services, so they could collect all the data and analyze all the data that was being used. And so by analyzing all the data of CPT codes and ICD codes and control substance control substances to each patient, they could see who's the outlier, which doctors are prescribing the most, and of a certain medication, whether it's Adderall or benzodiazepine or a opiate. And then they would go into certain areas. According to the documents, they would concentrate on certain areas. So Jeffrey Sessions, was the one of the big proponents of this. And I have a lot of documents about what Jeffrey Sessions wanted to do. And basically, he said is we'll go into these areas where there's a lot of crime, Philadelphia or New York City or Atlanta or Oklahoma, anywhere there's West Virginia, particularly West Virginia and Tennessee and whatnot, and we'll try to take out the doctors who are the outliers there, and we'll fix the problem because the cause of all the deaths, according to these documents, is physicians who are overprescribing and whatnot. And so but when they try to figure out all this, how to do this, they didn't know how to quantify who the overprescribers are. So there was a few studies that were done, and I could, provide them to you, but I've provided them to a lot of people. And what they determined is that they were going to use they had to come up with a metric because they didn't really have a metric into stratifying people beyond CPT codes and ICD codes and whatnot. So they basically developed the PDMP, prescription drug monitoring programs, which was and then they developed something called morphine milligram equivalents. And what they wanted to do was to say, let's stratify risk to patients by something called morphine milligram equivalents. And the more morphine milligram equivalents your patient is given, the more indicative that is of diversion, according to these documents. And we can target a physician that way. And so they went into Philadelphia, or they had these task force, wherever task force is set up, they get the data and they use the data to start targeting physicians based on those data. and that's how the system actually works. Um, and from my reading of it, and I'm also suing the government, saying that it's improper and proved to. It's something called judicial review, and I want the judges to go over that and determine whether there's something called strict scrutiny or rational basis scrutiny. Strict scrutiny means that if there's any racial or age discrimination, racial discrimination, gender discrimination, any discrimination, I want the court to look at that and determine whether that's occurring or not using these algorithms and these computer programs. And two, if there's rational basis scrutiny, to look at whether um, there's there's a rational reason to do this, because if more people are dying, then what's the point of doing something if you're getting a unintended consequence that is not comporting with the function of the government, right? The function of the government is to improve, an American government is to improve life, liberty, and the pursuit of happiness, and uh, whatever the founding fathers had determined it should be the function of our government. So I've asked the Third Circuit to look into this, and they've moved the case to extremely bright judge who went to Cornell. He's a chemical engineer, and he uh, went to Caltech, got a PhD from there, and went to Harvard, became a judge, became a lawyer, and now he's a judge. So he's looking into that right now, and I'm arguing that in front of him myself. Because when you get targeted, uh, a lot of things happen to a physician. One, you lose your licenses. The majority, a lot of times, the physician will lose their family members, their spouse will leave them. Um, if you have children, they might take the children, and then you can't work, and then there's a cascade of effects, which is like you might have to pay child support, you might not be able to work, you might have to take odd jobs. So the money gets driven, to extremely low levels, and lawyers are expensive, especially good ones, and you cannot fight them uh,
Right.
to obtain what information or justice. And I think you know they know that, and the government knows that, and they use their power to uh, obtain what they want. So this was what happened, in 2012 with Obamacare. It started, and then all the various different presidents and administrations used those powers as criminal forensic tools to target. And I can talk a little bit about the history of that if you'd like.
Well, instead of focusing on the past, let's focus on the future and kind of look at what are the what next implications of everything. So we have all this information. You have federal judges now looking at the racial implications. What's next? What's the likely outcome of all of these things that are going to happen?
Okay, well, something interesting that's going on, I can explain to you, is so what the government is using is something called predictive technology. And they're using this predictive technology is based on statistics. That, statistics at scale is often called artificial intelligence, correct? So artificial intelligence is now, the big buzzword in, in technology and whatnot. Um, I went to school at Rensselaer Polytechnic Institute, which is like a computer engineering school, and so I saw a lot of the early development of this technology. And so now we have, Chat GPT. I don't know if you've used it before, but we have now very robust artificial intelligence predictive systems. So you want to make sure that the government's predictive systems um, are not are not plagued by bias, and when they deploy these artificial intelligence systems to be used by law enforcement, that they don't target a group of individuals. So now, I'm working with a variety of groups around the country, including attorneys, to make sure that there's no, uh, in a positive way, trying to make sure that there's no bias in these predictive systems or artificial intelligence systems ongoing, because then you could train artificial intelligence systems to attack a marginalized group of people. Because what this artificial intelligence system is trying to do is trying to predict who's a criminal and who's not. Kind of like what you saw in that movie with Tom Cruise, Minority Report. So Minority Report is here, and it's been here for many years. And Ann Milgram talked about that in her TED talk, and how they were going to use data and collecting vast amounts of data through, either through computer images or facial recognition, and try to predict who's going to commit a crime and try to remove those elements from society and put them in prison. And you have a utopia that way. But in order for them to have a utopia, you have to make sure the data is correct, fidelity of the data, and you want to make sure you don't have a static society, or you want to make sure you have more of a dynamic society versus static society. And how do you do that? If when I was a kid, for example, uh, you know, people would be made fun of for being gay. I just remember that distinctly, and Um, now, we have acceptance of LGBTQ. They're treated as more uh, part of our society than ostracized people.
Yeah.
So I think in some ways that's a good thing, right? That you include many groups of people with diverse ideas, neurodiversity. It's called neurodiversity, right? We're more tolerant. For example, there's a Buck versus Bell. They used to in the 1920s. They used to sterilize people who were, mentally retarded, or well, who have mental defects or whatever like that.
Yeah.
We call it neurodiversity, and we're more accepting of these people. So I think
So
these are all.
if we were to maybe focus now on what we can learn from, or what we can practically implement from learning about potential biases in the medical data, how would this first manifest? Would this manifest as judges ruling in physicians' favors, the federal prosecutors changing their tactics to be more constitutionally sound? Where do you see the initial change taking place?
Um, well, I mean, it's hard for me to predict right now. For example, I'll tell you why. Uh, for example, the Ruan decision came out, correct? And the government went and criminally indicted so many physicians. And we can see the Ruan decision had really zero to no effect in terms of changing any outcome for very many physicians, or benefiting physicians in any which way. So, from a legal perspective, that's why I'm asking for the judicial review, rational basis scrutiny, and strict scrutiny, because nobody's ever really asked for that before, and we don't know where this artificial intelligence is going to go. I don't know where it's going to go in the future. So I'm trying to get that information. I'm trying to actually work with a wide variety of groups, because most people didn't know about it. When I started talking to a lot of people, they had no clue or idea, and it's only till I got these documents. A lot of people actually said, "Well, it sounds so crazy to me that the government would be using data in this fashion." Until I gave them the documents, and then they said, "Yep, you're right. So it has their markings on it. It has the government's markings on it. It came from them. So yep, this is a system that they're using, and new technologies will always come." And we saw with thalidomide, right? Thalidomide came out and caused huge havoc to a large number of people, and that had to be pulled off the market, and it was a disaster. And I
Yeah,
think
but thalidomide led to an increased scrutiny and increased regulation to the point where potentially the FDA is now a massive behemoth. Do you I would believe that you're arguing in the opposite sense, that by identifying biases in data or biases in government policy, that there should be less government intervention in healthcare.
Well, yes, I would say from my perspective, um, seeing healthcare over the last 40, since I was born here, grew up here, I would say that the government intervention has created a static and petrified um, petrified culture in medicine. And the reason I say that is because I ask people all the time, where's our Elon Musk of medicine? We have so many brilliant people in medicine. Where's the name me someone that's very famous in medicine. I'm not talking about Louis Pasteur and you know uh, the most famous people out here is Paul Farmer, who went to Haiti and helped with the aid, helped figure out ways to reduce in terms of health policy, reduce the problems with AIDS and transmission of AIDS. Or they'll name Anthony Fauci but he was a government employee, and so we don't have many great inventors. A lot of the great inventors who came out have lost their medical license. So I'll tell you, in our local area, there was a guy, Dr. Norwood, and Dr. Norwood, he lost his medical license and whatnot, and he invented the three chamber heart, which was a reptilian heart to help the hypoplastic left heart syndrome. So what I've seen is, in terms of medicine, is doctors don't invent as many medications because of cost and the capital required. For example, I read in the 1960s to bring a medication to market would be roughly $6 million, and now today it could be $1 billion to bring a drug to market. So the ways that a physician can innovate are limited. The capital expenses are very prohibitive. A doctor cannot even patent a technique so that to develop the capital to maybe build a hospital or something like that. A doctor cannot own a hospital anymore. There's certificate of need laws. So there's so many ways that a doctor is constricted in thinking outside the box. And now with data analytics, if a doctor starts using a CPT code or starts using different medications that the insurance company or the HFPP considers an outlier, they'll criminally indict you. So at this stage of the game, I don't know what a physician would do to really innovate or be like the computer, the Silicon Valley, or to be a true innovator in that field. I
Yeah.
and I would. Do you see this the same thing? Because you've talked to people all over the country. What's your opinion? Am I having a misopinion from my conversations with people, or do you find that the same things happen?
I see it as there's two issues superimposed onto one another. One is, why are there no physicians who individually want to innovate or identify new discoveries in medicine? I would contend that many of the physicians who do rise to a certain level of prominence end up becoming immediately politicized. If you look at, let's say, you mentioned Anthony Fauci. Uh, he has been incredibly polarizing, and I think justifiably so, for some of the uh, comments he's made that perhaps he described as noble lies, other people would consider a form of deceit. Then you look at folks like Peter Hotez, who want to have conversations about vaccines, but only under certain terms with certain individuals. Then on the other side, you have people like Vinay Prasad, who takes a libertarian bent, but inevitably gets his fun on social media as well. It's very difficult to separate the political animus of the time with physicians who rise to a certain level of prominence. And I think those who truly want to be innovators in this space and want to avoid the political stigmatization that is just so pervasive throughout healthcare end up going into industry or starting their own companies. So it's never Dr. Neil Anand invents a new drug. It's Neil Anand Incorporated, venture backed biotech company, gets FDA approval for drug XYZ. The whole nature of innovation has changed because medicine at an individual level has become too polarizing. So those who are truly innovative hide behind the scenes of a corporation, whether that's a startup or a larger conglomerate. And then innovation pipeline through there is just fundamentally different. I I think that the federal government, particularly the NIH and other organizations, have done a terrible job removing a terrible job not removing their political biases and how they evaluate grants, how they look at certain physicians. And I think that's a byproduct of what you're seeing in medicine, that there's no room to separate politics and law from medicine.
I mean, like for example, I mean, there are not very many surgical procedures being invented. It seems like, and I'm just because I'm an anesthesiologist, so I can just look in terms of the procedures that were being invented and what I saw in my time, and you know, I I saw less drive because a lot of these surgeons would worry that they would lose their license or something if they had a bad outcome from a procedure. So like for example, the heart lung machine when that was invented by Gibbon, his first couple of patients died.
I
But
mean, no doubt that like healthcare has
yeah,
become more litigious than ever before. And if you look at, the polio vaccine, right? The original version uh, killed a lot of people, right? Jonas Salk's polio vaccine version killed a lot of people, and it was actually Sabin's version of the polio vaccine that we use currently today. I don't think that's only the case. So let's say the number of surgical procedures, you can get enough NIH red tape to protect yourself as a surgeon if you are truly committed to creating a new surgical technique and preventing yourself from the litigation that may come. That may create exorbitant clinical study costs, that may create exorbitant insurance fees that you're going to have to cough up, but you can find the legal protection. And that's the point I think you're getting at, in that it's less about the actual innovation, about that truly entrepreneurial drive to improve medicine, and more about how can you diversify out the legal risk? Can you get a clinical study that has enough NIH backing to then cover legally what could be a potential downside to a research project? Or can you work under a corporate conglomerate that'll protect you legally if something else happens? So when you start to think in that vein, it's less about taking the risk of success and more about protecting against the risk of a downside. And I think that doesn't bode well for any sort of innovation.
right. So because for example, I grew up in Albany, New York, and there was a guy E. Donald Thomas who invented bone marrow transplant, and he invented bone marrow transplant in Cooperstown, New York. Now, Cooperstown, New York is a very small town where the Baseball Hall of Fame is and whatnot. And I remember going there and I did some rotations there and whatnot. And it was said that basically if that was tried today, that he would probably lose his license or that that kind of work couldn't be done in a small hospital like Cooperstown, where somebody's truly groundbreaking. So, when I talk with these physicians and numerous physicians, a lot of them have said that, medicine's become so static and petrified, our culture, that it really is the spirit of innovation is dead here in terms of medicine and needs to move to another country or some other country will proceed forward. And that's to me is very sad because if you study the history of American medicine, a lot of our surgeons stuff went to Europe, were educated there. They spent 1 or 2 years there, and they came back. And in terms of anesthesia, we had Horace Wells and Morton who invented anesthesia here, and they had actually terrible. They didn't really benefit from that, and I've noticed that in our physician innovators are not extremely celebrated in our country, and they're extremely demonized. So my question to you is, because is it? Do you feel like it's dead, or is it static? Is it petrified? Can it be changed? And that's what concerns me now, especially when I see this data analytics and this criminalization. Because how can so many doctors, thousands of us at one time, be criminalized like that, just using data? And if that can be done, why can't it be done for anything?
Yeah, I think it has been done for quite a few other facets as well over time. I mean, what's going on now to physicians is very similar to what was going on during the Salem witch trials. There's always been an undercurrent of anti-intellectualism in this country that has pervaded most prominently in the medical and health sciences. You look at people's reluctance to practice sanitization. You look at people's reluctance to adopt public health measures. All throughout the current of American society, it's always developed despite people's resistance to support public health or health care. And I think America has been entrepreneurial enough to overcome that. I think what has happened is that the legal gears have finally put a lot of that health innovation to rest. And I would agree with you that a lot of innovation does take place in other countries, and a lot of American companies, American health corporations know that. That's why a lot of these corporations, Johnson and Johnson's, Pfizer's of the world, have CROs, clinical research organizations, in other countries. They do research in India, they do research in Israel, and then they license in the United States. So what happens is that the legal veneer of oversight has effectively transplanted the spirit of innovation and the clinical nature of medicine at its most fundamental level. So that's why you see innovation having a very corporate overtone that taking place is only at the largest, most well-funded corporate healthcare systems. It's not going to exist like what you mentioned, the small hospital in Cooperstown or Coopersville, because you can't afford to overcome the legal liability to innovate in a small independent hospital. Hell, you can't even afford to pay your bills in a small independent hospital these days unless you have some sort of municipal grant or somebody who's politically affiliated to say if this hospital shuts down, it's going to create an economic downturn in that area. So I think it's all pointing just to this general ethos that people in America, particularly policymakers, believe that the legal oversight is more important than the spirit of the individual patient care when it comes to healthcare. And that's why you're seeing data algorithms used to target physicians. That's why you're seeing abortion becoming a political talking point, IVF becoming a political talking point. They're turning certain oral contraceptives in Louisiana into a controlled substance. Why? So that they can use the DEA and state authorities to target abortion providers the same way that they were targeting opioid prescribers. It's flagrant if you understand what the ethos is around those who are trying to enact these policies. And I think what are the effects in healthcare? I think we're already seeing the effects, right? Most per capita spend per patient, middle to below average clinical outcomes. There's only one thing to blame, and that's the legal oversight in healthcare. It's become too cumbersome and it's harming medicine. It's hurting patients.
Right. I mean, the cost has gone up tremendously, and um, you know, the
Do you
fact that
know how that cost is broken down? Like per capita dollar spent on healthcare, how much of that goes to malpractice insurance, legal liability considerations, tort reform, and how much does it actually go to the care of medicine? Do you know anything about that? I'd be really curious to see if they
I
actually
mean, I had
even
my
have that.
own business. I can tell you that um, a large amount of staff was to deal with the insurance company, the prior authorizations, assisting with basically bureaucracy. A lot of my time was spent dealing with bureaucracy, uh, with insurance companies and how the decisions are made on a daily basis with each patient, with each medication, and a lot of the decisions were out of a physician's control. I mean, that's just
Would
the
you
truth of
would
the today.
when you were running your business, would you have taken a cut of your top line revenue if that meant that you would have less bureaucratic overhead and less legal liability?
I mean, probably not because uh, you know, if you're going to grow and compete, you know, you're going to have to, if you really want to compete honestly with every system and be the best you can, you're going to have to compete in all different ways. And otherwise, how are you going to have another Mayo Clinic? How are you going to have, you know, right? The Mayo brothers started the Mayo Clinic, and you see where Mayo Clinic has become today. That's because those Mayo surgeons really try to push the envelope. So for me, why is there a bureaucratic headache? Maybe artificial intelligence will solve that. Maybe artificial intelligence will have all the healthcare law in the artificial intelligence, and it'll be able to tell you whether what's right or what's wrong, what the doctor can do, what the doctor can't, what the insurance company will allow. So maybe it will. the decision making can become extremely rapid, right? And the government can control. For me personally, I'm a bottom up kind of guy, and I'm not a top down kind of person. So personally, I feel like most problems are solved at the business level, right? The American business level, the transaction between a individual and the service provider or the goods provider. I to me that is very important. That's where the competition occurs, and that's where it's important that we concentrate our resources. So when I hear these top down approaches like, okay, we'll use data analytics, we'll look at the data, we'll find out who the good doctors and the bad doctors are by looking at the data, and then we'll know who's committing the fraud and whatnot. But then they seem to me to be targeting mostly physicians of color or independent practitioners, or and I talk with physicians all over the country, and I hear all these stories, and they're frankly horror stories. Um, and a lot of them seem to be desire to innovate and try different things or
Yeah.
use different things or medicate or medical technologies that are disfavored by numerous physicians. For example, I've talked to people who are interested in chiropractic or people who are interested in Ayurvedic medicine or acupuncture and qigong exercises. And if you talk to many physicians, they'll be like, "Oh, I think that's total bullshit." But those practices have been around for thousands of years, and they're not totally stupid. I mean, I remember my grandmother giving me, some concoction to drink, and I drink it, and I feel better. So they didn't know. It's not like, you know, you have to give a healthy respect, I think, to a wide variety of cultures and their medical history, and not throw things out because I was invited to give a lecture in Cambridge one time on the invention of neuromuscular blocking agents, which was, a highlight of your career because Cambridge, William Harvey went there and he discovered, the circulation system and whatnot. And the way they discovered neuromuscular blocking agents was they went to the jungle, um, and those poison dart frogs, the curare. They were able to look at that technology and export that technology to block, during surgery because the muscles would tighten up. Even when you knock someone unconscious, their muscles would be tight and the muscle needed to be relaxed so the surgeon could open up the abdominal cavity and actually do an operation for a long period of time. So that
Yeah.
curare really helped, and that came from the middle of nowhere, um, in the middle of a jungle. So um, these ideas, and today, for example, I read the story. If you read the story of someone truly amazing, which would be Benjamin Carson, right? If you study Benjamin Carson's story, and if you read his books, I mean, his mother was illiterate, couldn't even read. He was a
Yeah.
single mom. He grew up, and if you read his story, he did an operation by himself. I don't know if you know that, but he did an operation by himself because someone came in and he did the operation without his attending. And he explains his story that the attending was said you did the right thing, you helped the patient, uh, and decided not to um, terminate him or whatnot. But
Yeah.
you can see that today that many program directors would just terminate him, and you wouldn't have a Benjamin Carson today. And
Right.
when I talk to people who lose their residency, because I talk to a lot of doctors and physicians who lose their residency or whatever, they can't ever get another residency. They're basically discarded. They even can't even work as a nurse practitioner or something as a physician extender, and their whole life becomes destroyed
Yeah.
by the process. So I'm wondering what's happening in medicine. How do you get
And
out of this?
exactly. No, and I appreciate that. It's always, it was great to talk to you. Unfortunately, we do have to head out, but
Okay.
listen, let's continue the conversation, and I want to hear more about the FOIAs and what we can uncover because the key thing is like the public is more and more aware of this. You see articles and all coming about that. We just need to stay on the pulse and make sure that people are fully aware that this is a systemic process by the government, and the documents prove what we've been saying all along.
Thank you so much, Jay. I appreciate it.
Thank you.
All right, bye.